Okay, hey, welcome back. This is part 2 of day 2, how to close new patients without having to resort to high pressure sales tactics. So if you guys were here, thanks for coming. If you were here last week, this was actually, obviously part 2 of a previous training, which we did last week. If you don't have that, you can certainly get access to that through both our group as well as at mypatientstream.com/school. Cool. All right. Real quick. What is Patient Stream or New Patient School all about? So New Patient School, we have one goal. Our primary goal is to help docs grow their practices by providing an amazing software that allows you to run niche specific marketing campaigns, training on the most effective methods to increase new patient conversions like today, and a community of docs like yourselves that have a drive and a passion to get more new patients. Okay. And we want to do it so we can make it really easy for anybody to do this, even this dumb dodo bird. Right. And so we're excited to have you here. Thanks for coming. And let's jump into it. So today, our teacher is Dr. Andrew Wells. Andrew Wells is a good friend of mine. He's cool enough to come and share all of his insights and years of experience from running his own practice, from helping other folks run their practices. And he's a great guy. He is the owner of Simplified Integration. So if you're looking for help integrating your practice, he can save you a lot of money and he can do it a lot quicker. He's great for that, as well as he's got an amazing podcast, Simplified Integration Podcast, which you should listen to. He's got great stories, and he's got a really cool way of not only teaching and sharing experiences, but relating and conveying that information through really cool stories, which you'll hear some of today, I'm sure. And then obviously this is something he and I have in common. First and foremost, we are husband and fathers, and we're very proud and grateful for our families. So anyway, Dr. Wells, thanks for coming, and thanks again for doing this. We're excited to get started.
Yeah, thanks for having me. This is something that I really enjoy doing, and I hope the docs listening to this can take this information that we're talking about and teaching and really put it into practice to help them help more people and help grow their practice and just get more satisfaction and more production and just make their practices run better. So let's jump into it. So this is again, like Sam mentioned, this is a continuation of the last training, and we're really diving into what we call the day 2 process. And just let you know, we call day 2 the ROF. We call it several different things, but this is essentially where the patient comes in, and we're gonna present what we found on their first visit and make some recommendations in terms of therapies, and then close the patient for care. And a little bit. So we're breaking this up into 3 trainings. We actually may end up making 4 trainings out of it. But last time we kind of went on just a really high level look at the mechanics of day 1. And now we're going to actually break down what happens when you're presenting recommendations to a patient and how to do that. And then next week on the next training, we're actually going to do a live role play activity where I'll be the doctor and Sam's going to be the patient. And we'll show you how we actually run through a day 2 with a mock patient. So
it's going to be awesome. I'm excited for that.
Yeah, and me too. It's going to be a lot of fun. So this is, you probably noticed if you were on last week, this is the same slide we used last week. So here's where we're at right now. We're going to focus really on the gray text here. So we talked last week about just making sure that the patient's coming back with some hope, so they know that you can help them. Also talking about some of like what Sam calls like the soft skills. So making sure that we're addressing the tone in the room, making sure that you're building rapport with the patient before just diving into information. And really what we're going to focus in here on the bottom, the gray text. So how to review findings from day 1, how to make sure that the patient is they actually understand what you're talking about and confirming that they understand. We're going to walk through how to review patient options and review recommendations in a really systematic way that makes sense for the patients. And then also how to provide financial options at the end.
Awesome.
So big concepts to walk away with. Number 1 is how to position yourself as an expert and not to feel or not to be seen as a salesperson. I think that's one huge key that we've learned over the years, is that if you want to have a high level producing office, you don't have to be really salesy. In fact, I would say the opposite. If you're not salesy, that's actually more
Yeah.
beneficial. And then we'll learn some like little key phrases and questions and triggers to get your patients engaged in what you're presenting and to get them to take some action. And then finally, how to create and develop a team that will help you convert patients on a much higher level than just doing it on your own, and how they can help support you in this process. All right, so here's where patients should be at this point. Number one, they should have been through a day one process. So that's a consultation and exam, which we went over on 2 weeks ago. They should also have, again, they should be coming back to your office with some sense of hope that you can help them with the problem they came in with. And then finally, right before you're going to deliver your results, they should have had some sort of patient education process, whether that's a video that you had them watch or a group report of findings that a lot of doctors do. But they should be somewhat educated on what you're about to present them on day two. And now this formula, by the way, is the same formula, whether you're an integrated office, maybe you're a functional medicine office, a weight loss office, a straight chiropractic office. This formula doesn't change. And we've used this formula successfully across multiple different platforms and disciplines. And so I want you to understand that if you can plug this formula into your office, it doesn't matter what type of practice you run, this is going to really, really help increase your conversions. And this is actually what we're going to dive into today, these 5 different steps. So we're going to break down each step in detail. So the first step is pre-framing. We talk a lot about pre-framing, and we do this for lots of different reasons. It's a psychological tool that makes it works on a lot of different levels. But number one, we want to make sure that our patients are feeling secure in the process that we're taking them through. And having done thousands and thousands of reported findings over the years, there's this moment when patients walk in and they're coming in to find out what their results were, and also they're going to find out what you're going to recommend. So you're going to go over, financial information and insurance information. And if you've done it long enough, you know that kind of deer in the headlights look that patients have when they come in your office, or they have this concerned look or stressed look. There's some really key things that you can do here to help put your patients at ease, so that they're not just focused on, right? Like typically they'll have like one concern. Like most of the time it's, how much is this going to cost? Like, is this going to break the bank? Can I afford it? So there are some things that we can do here just to help put your patient at ease, so they can actually focus on the really important information that you want them to understand when it comes to their health, and also the benefit of the therapies that you're about to deliver. So let me give you an example here. 2 weeks ago, I went into the dentist because I had to get a tooth pulled. I had a bad tooth, and my choices were a root canal or just to remove it. And I don't like the idea of having dead teeth in my mouth long term. So I said, I just want that sucker out of there. So I walked in. It was 7 o'clock in the morning. I sat down in the dental chair. The assistant came in and she put a blood pressure cuff in my arm, and my blood pressure was 148 over like 98, or like maybe more than that. But it was like sky high, and I'm like, oh my gosh, like that's like go to the hospital type blood pressure. And normally my blood pressure is a little bit low, and I'm like, holy cow, like that can't be right. Like, do it again. And she goes, I'll do it again in just a minute. But most people get nervous. This is like dental blood pressure levels right here. So she's like, you're about to get your tooth pulled out. That's pretty normal. So she goes, listen, so here's what's going to happen today. She goes, I took your blood pressure. The dentist is going to come in and she's going to numb up your gums and give you a little injection. You might feel a little pinch on your gums, but it's super easy. She goes, after that, you're not going to feel a thing. And it takes us about 5 minutes to, actually, she said it'll take about 10 minutes for that medication to sort of numb your tooth. And then after that, we'll take the tooth out. It takes a couple minutes and then you'll be fine. You're not going to feel a thing. Have you bite down on some gauze afterward, and we'll send you home. So this whole thing's going to take about 30 minutes, and it's really easy. She said we do this all the time. Dr. So-and-so loves pulling teeth. She's really good at it. And you're going to be just fine. And you know what? Like, yeah. And you know what was cool about it is that like they were so calm, like the assistant and the dentist, like super chill people, really calm. And so she walked me through what was about to happen. And then I said, you know what? Hey, take my blood pressure again. And she did it. And within that scope of a couple minutes, my blood pressure had already dropped like 20 points. And the reason I'm sharing this story with you is because what you want to do in the beginning of a day two, the beginning of the ROF, just think, what can I do to lower my patient's blood pressure, so to speak? So what can I do to help put my patient at ease?
Yeah.
And so some of that's just pre-framing. So here's what we do. Just like the dental assistant did for me, what we would do for day two patients is we just start off with, so keep in mind, they may be bringing a spouse in for the first time. So what we want to do is just start with some small talk, like, hey, nice to see you. Talk about the weather. Hey, nice shirt. Like whatever you can do to just make some small talk, make them feel comfortable, make it seem like you're a real human being, right? Not just like a robot. That takes maybe a minute or 2 minutes. And then after that, we just break up what the appointment's going to look like. So it goes like this. So Sam, welcome back. We're really happy that you're here. So what we're going to do today is the first thing we're going to do is we're going to go over your exam results from the last visit. After that, so number one, we want you to understand what the problem is. And then after that, we'll talk about what we can do to help fix that problem for you. And at the end, we're going to talk about how much care costs. We'll talk about insurance, and we'll go over exactly what this is going to cost you to get care here. Does that sound good?
Yeah.
And then patients say, yep, that sounds cool. So you just tell them what you're going to do. And then right after that, I would say something like, now here's the sales pitch. This is it. So, the good news, Sam, and the reason we have you back here today is because we see this problem all the time. We get great results. We're really confident that we can help you. So let me show you exactly how we're going to do that. That's it. So that's the pre-frame. So sometimes what happens is doctors will get in the room either because they're rushed, or they just sometimes I think doctors get so used to doing report of findings, and they just kind of forget to do that first part. But as small of that detail is, I think it's really powerful and really impactful just to kind of lay out what's going to happen in the next 20 minutes or 30 minutes with the patient.
Yeah, I think it's everything. I think if you skip this, I think if you don't do this, you are setting yourself up for failure. In fact, if you're a doctor and you have been experiencing really low conversion rates and you are listening to this video right now, this is probably what you've been missing. Because much like, just to kind of go back just a second, your blood pressure was not high because you consciously made it high. It was high because of the subconscious, of the subconscious mind. And it's so interesting how we have these storylines and we have these ideas in our head that control a narrative. Okay. And they control that narrative until something happens to change the narrative. Right. And in this case, when you address, I got a helicopter. I don't know if you can hear that. I got a helicopter flying over my head. It's kind of weird.
They found you, Sam.
That's right. If you're listening to this, you guys, I cannot confirm nor deny whether or not it was me. Subconscious. So, the subconscious brain is really your enemy. And what you're doing here is you are, everybody's kind of waiting for the shoe to drop, whenever they go in for, any type of thing that they perceive, again, their storyline is going to be a sales pitch. And the second you say, hey, this starts out like a sales pitch, and then after that, it's your choice. And you tell them exactly what's going to happen. They're like, this is different. I don't have a frame of reference. Like, this is not programmed into my brain. What's going on here? Right. And so all of a sudden they're at ease. Okay. And when they're at ease, the cool thing, long-term, the long-term objective here is that we can convey our education, our information in a way where they can accept it, where they're actually able to accept this new information. So pre-framing, and pre-framing has been part of the last training. It was part of the training before that too, right? It's been like 2 trainings, right? I can't tell you. Go ahead.
Yeah, it's all, and so from whatever we started talking about pre-framing, we do it at every step of the process. So what we're doing here is that we're always telling them one step ahead, just one step ahead. So here's what we're doing in the next 20 minutes.
Exactly.
And that's all, because that's really what people can digest and understand. And again, it puts them at ease. And, thinking back on that blood pressure story, if you were to see me walking in the dentist's office, I'm like cool as a cucumber. I wasn't afraid to get my tooth pulled out. Wasn't nervous about it. But physiologically, my body was having a response. I wasn't
It
conscious
was.
of it,
Yeah.
but it was, my blood pressure was sky high. So something was happening inside, like Sam mentioned, my subconscious mind. Obviously, I wasn't aware of it because it's subconscious, but it was there. And so as soon as she did that little pre-frame for me, physiologically, my body went back to normal,
Yeah.
or
Love
pretty
it.
close to normal. So
Love it.
yeah, so here's where we start to talk about. So before we're going to make recommendations, we first need to teach the patient so that they really understand what their problem is, and make it very understandable and relatable to them. Now, at this point, remember, like, you should have had some sort of patient education process. So if you're throwing up X-rays, a good test to see if your patient education process was any good is to see how well your patient responds to looking at their X-rays. So even though we do, like, so that, for example, I'm going to go over a knee pain patient. So this is somebody suffering with osteoarthritic knee pain. It's a really common condition we see in our office. You can plug in your own problem here for patients that you see, but what we're doing is we're showing them what normal looks like, and then we're showing them, so that way when they see their, we're showing them what normal and abnormal looks like. By the time that they see their X-ray, they should know exactly where they fit in this paradigm. So on the left, we show them, here's what a normal knee looks like, or a grade 1 knee, grade 2, grade 3, and then the severity on the right is grade 4. So what we do is when I pull up the patient's X-rays, I don't explain anything on the X-ray. I say, so Sam, here is your knee. Tell me what do you think? What do you think is going on with your X-ray here? What do you notice? And
Yeah. It's more narrow on the left-hand side.
yeah, that's absolutely right. So on the right side, that's normal space. On the left, that's decrease. You're absolutely right. So Sam, based on this decrease in space, what grade of degeneration do you think you are?
Probably between a 3 and a 4.
Yeah, I think, yeah, you're pretty close. Actually, I'd say you're more of a 3. I wouldn't say you're so far to a 4 yet, and but you're really close. And you know what? That's good news, because since you're in a grade 3, that means that there's something that we can do about this problem. So that's really all I do. So Sam, in this example, you've just identified the problem. You've put yourself on this grading scale of severity. And so the next question I would have for you is, so do you see why you're having knee pain? Or another way of phrasing it, do you see how this would cause knee pain?
I like that. I like that one maybe better for me. If I were to do this, I think I would use that one.
Yeah. So yeah, and the point is just that you want to make sure that the patient's like, yeah, they're identifying, yep, that's causing my knee pain.
Yeah. Yeah.
And so, and it should be pretty obvious, there's not, most rarely do you get a patient be like, well, it could be genetic. It's like,
hey, dummy,
and
you just said so on the X-rays. Yeah, I got it. Yeah.
yeah. So the point I'm trying to make is, yeah, and when someone says something like that, I'm like, yeah, that's dumb. But you never want yeah, it's like, well, let's go back to the X-ray and take a look at it. So you just want them to understand that that's where the problem's coming from. So the next question is what do you think will happen if you didn't do anything about this problem at all?
It would get worse.
Exactly. And so the question I have for you is this something that you want to get resolved now?
Yeah, I think so.
Okay, great. So okay, so that's it. So really simple questions, but what I find docs, the problem I think docs have is they get uncomfortable asking those questions, and then also uncomfortable waiting for the response. And what I see, this is usually with like docs that are kind of like right out of school, or maybe uncomfortable with that really mild level of confrontation, is that, and I used to do this. I used to ask the question, and then I used to answer the question before before the patient could answer it. So I'd say, so what do you think will happen if you don't do anything about this? It's going to get worse, right? And the patient's like, yeah, sure.
Yeah.
Right. Yeah. So just like I did, and even, Sam, you did a good job of this as we're kind of sort of semi role playing this, is ask a question and then let the patient be quiet and give the patient some room to think about it and then to answer the question.
Yeah, it's
And
funny how the quiet is your friend, and it really is a pivot point. And just as it's kind of funny, and so we're actually doing this training, this recording a second time. The live training we did corrupted the file corrupted. In fact, the meeting ended early, and it was a little awkward. But what going through this again, I'm almost thinking, this is a transitional phase. Like, this is the transition to the quote close, right? This is for them to be able to accept the next, to go through the next phases here. This is a transition. It's like, hey, we've collectively identified the problem. Now, I can't tell you what's going to happen. You have to come to that conclusion yourself. And if you do, then we can proceed. If you don't, then we're done. Right? And I really like you said, everybody as a service provider or in any role where you're like saying, hey, this is my advice. We all feel a little bit like we need to protect or whatever, but the awkwardness and the silence is your friend, and you need to give that silence the ability to do its work, because what's really happening is change is happening. New ideas are being adopted. If you were to, I want to maybe take that question number 2 to another level. Even, what do you think would happen if you don't address this for the next year? Okay. And you sit there and you let them answer. What about 5 years? Because you could almost take that if they could say the next year, what about 5 years from now? What about 10? So the question is this something you want to fix? Right? I think there's different approaches to doing this, but the point is to, if you want to transition into your recommendations and have them carry any level of weight, the patient has to decide, has to choose that, right? And this is your opportunity to do that. So I guess the benefit of doing this again, Andrew, is that I'm having new thoughts about the process, and I think it's awesome.
Yeah, you picked up on, I don't think we did a good job articulating this in the live training, but you're absolutely right. It's when the patient verbalizes and they've made a decision, like, yes, they're saying, yes, I wanted to fix it.
Yeah.
Then it's okay. Then they've already told you they want to be a patient. Now it's just a matter of figuring out how to make that work. So they've already said, yes, I want to be a patient. That's one way of saying it. But yeah, you're right.
Love it.
All right. So step 4. So now we're gonna make the recommendation. So we identified the problem. The patient says they want help fixing the problem. Now here's how we're gonna fix it. So I added this special note in here because if you're hopefully you're using Sam and Patient Stream to do your marketing, you know that Sam creates some really clever ads or hooks to get people to come into your office. And so one thing that I think is important to mention is that if you're doing some kind of special promotion, like for example, you're saying, we have a solution for knee pain that's covered by Medicare. And part of your solution is covered by Medicare, but also part of the solution may be an out-of-pocket cost. You want to make sure that you're addressing this topic before you start jumping into recommendations. Because if let's say you have like this freebie, like this one therapy that's covered by Medicare, but then there's also like this massive out-of-pocket cost that they have no idea that they're about to get pitched on. It's going to come off as very salesy, very bait and switchy, and it's going to piss the patient off. So the way to handle this is another pre-framing strategy is we just say, all right, Sam, so we're going to go over your recommendations, and we have some recommendations that are covered by your insurance. We also have some recommendations that are not covered by your insurance, but we find very valuable and really effective at helping people with knee pain, just like the problem that you're suffering with. So do you want me to go over the insurance therapies? So here's what we can do. We'll go over the insurance therapies. I'll cover the out-of-pocket therapies. And at the end of this, you can decide which one do you want to do. You can do both therapies. You can just do the insurance stuff, and you can pick what you want to do. Does that sound good?
Yep, that sounds good.
Okay. So I kind of butchered that a little bit, but I hope you get the point. Is just saying.
Yeah, the idea, sure.
Yeah. Just let them know you're going to show out-of-pocket costs, and then also you're telling them, you're giving them the option to decline that if they want.
Pre-framing again. I mean, you just pre-framed again.
Yeah. Because if you don't do that and you just throw up these cash-based therapies and they're under the impression that this service is covered by Medicare or by insurance 100%, that's totally going to derail your report of findings, and they're going to think that you're a sketchy doctor.
Yeah.
Instead of just making it a choice. So now when you're making recommendations, there's a system to doing this. There's a sequence to it. And just to be clear, so let's say you have, for knee pain, let's say you have 4 different therapies. You're going to go over one therapy at a time. And for each therapy, you're going to talk about the feature, the advantage, and the benefit of that particular therapy. Once you've covered that therapy, you're going to jump to therapy number 2. Here's what this therapy does. Here's how it works. Here's how it benefits your knee, and so on. So you're going to cover each therapy one at a time. And all of these therapies are going to total up to your total plan, your total patient plan for solving whatever issue the patient's having. So for example, I'll show you the knee example in just on the next slide here. If you're doing, let's say, functional medicine, the first therapy would be supplementation. The second therapy would be diet change. And the third recommendation could be like stress relief protocols. So in this scenario, as we're using a knee pain patient, the 4 therapies are hyaluronic acid, a knee brace, knee decompression, and regenerative medicine. So I would start off, first of all, with the insurance-based therapies. So Sam, the first therapy we're going to recommend, and this is covered by your insurance, is called hyaluronic acid injections. Now, the great thing about these injections is it provides lubricant and cushioning in between the bones in your knee. There are very few side effects. It's not like a drug or like a steroid. And we find that our patients have relief for 6 months to a year with these types of injections. And again, there's very few side effects. The great thing is you'll notice a change almost immediately. So you can start walking with less knee pain. And at the end of the night, you're going to have a whole lot less inflammation and pressure on your knees like you do right now.
You just did it perfectly. It was feature, advantage, and then benefit. And the benefit part's important, right? Because the benefit part is the context. It's the answer to the question why. Like you didn't just throw in, and if we were to go back to the previous slide, you didn't just throw in hyaluronic acid injections willy-nilly. You threw it in there for a purpose, and you're making these recommendations. And as you go through that process where it's benefit, so hyaluronic acid injections, advantages, quick relief, you'll start feeling, actually, no, that was the benefit. The advantage was what?
The advantage is it provides lubrication and cushioning in between the bones in your joint.
Yeah. And then the benefits, the good part about this is you're going to start feeling like really, pretty quick relief from pain. So yeah, that was a great example. So I won't interrupt you anymore.
No, actually, I totally didn't set that up right. And you're absolutely right, Sam. So the benefit is what most doctors forget to talk about. And we talk about like the widgets and gidgets, whatever, like the actual parts of the system, but those parts aren't important unless it benefits you in some way. So this actually goes all the way back to day 1 in the consultation. The reason that consultation is so important is because when you get a patient to say, hey, why do you want to be out of knee pain? It has to be more than just pain. So if Sam told me, look, I really want to be out of knee pain because every time I end up playing with my kids, at the end of the night, I pay for it, and it makes me it makes me hesitant about spending time with my family, and that really concerns me, especially with the young kids. Boom, like that's like his hot button. So now in day 2, when you can say, hey, listen, Sam, when we do these hyaluronic acid injections, you're going to notice that after you play with your kids, you're not going to have the same pain and inflammation that you had before, and you can go to bed without having to worry about whether or not you can play baseball with your boys tomorrow.
Yeah.
Boom. Like that. Okay. That is something that's the power there. So if you're skipping that part, you're missing the point in that feature, advantage, benefit. That's the powerful stuff. So don't skip the features and advantages, but also mainly don't skip the benefit.
Yeah.
So you cover that for the first therapy, the second therapy, so like a knee brace. So Sam, we're going to give you this knee brace. This is not like the knee braces you find at CVS. It actually has a special hinge that's going to take some pressure off of that middle part of the joint where you notice that you had a loss of joint space. And so what that does is it takes all that pressure off so that you can play with your kids and spend more time on your knee without all that physical pressure. It also makes that injection, the hyaluronic acid injections, a little bit more effective because that gel can move around a little bit more easily in your knee, and it's going to provide you with some a whole lot less pain, and you're going to be able to do more activity with your kids wearing this thing.
Yeah.
So those are the services covered by your insurance. Is it okay if I go through those cash-based services with you?
Yeah.
Okay, cool. So the reason I go over these therapies again, Sam, is because they're highly, highly effective. The first one I want to talk about is the one that you tried out yesterday. This is knee decompression. This is the picture of the lady sitting in the chair. Knee decompression is just like decompression for your spine. What it does is it slowly separates the two bones in your knee, and it provides, it just takes all that pressure off the joint. It provides pain relief. It also gets some healthy motion back in your knee that you haven't had for years. And in conjunction with the knee brace and hyaluronic acid, they all work together to make sure that we're taking as much pressure off the joint to alleviate pain and to help make sure that your knee is healing in the fastest, most effective way possible. So again, you don't have to worry about, all the activities you want to do and spending time with your family. And then finally, we have regenerative medicine. This is the most powerful tool that we have in our bag of tools. This is the only thing in healthcare that will actually help stop and in some cases reverse the signs of aging in your knee. So up until now in healthcare, the only real tools that we had were things that just cover up the pain. These are the things that you've done before, like cortisone injections and pain medication and some, physical therapy. Sometimes you notice some relief, but it wears off over time. Well, regenerative medicine is different because it uses cells to actually repair damage in your knees. And the cool thing about this is there's no known side effects. It's a one-time injection, and you should notice relief from these injections for a long time. And so not only will it help you relieve pain and do all the things that you want to do with your kids, but it also, most importantly, is that it's going to help repair your knee so that so down the road, if you're thinking 5-10 years down the road, someone in your position is often looking at knee surgery or a knee replacement. Well, we now have the technology and tools to be able to avoid that. So this is why I really wanted to talk about, it is not covered by your insurance, but we think it's that valuable and that important that we wanted to offer it up so that that this is an option that you have when it comes to fixing your knee.
Yeah, I love that. I'll add in one more thing that I recall from our training earlier today. And that was just in that last line, it's not covered by your insurance, right? I would say something to the effect, just to borrow some credibility from other things that people know, because when people hear that it's not covered by your insurance, they automatically think, well, why isn't it covered by insurance? Right. So in order to get rid of that idea first, once and for all, you say, and a lot like even proven conditions like LASIK surgery, it too is not covered by insurance, although highly effective, right? Because everybody knows LASIK surgery is extremely effective. And I mean, these are people cutting in your eyes, but it's a cash service, right? So if you feel like you need to, now every person is a little different, but if you feel like you need to, throw some credibility, some borrowed credibility right into the conversation right there. I think that's been proven to work really well too.
Yeah, that's genius. I love that. Perfect. All right, so we've covered the therapies. Now it's time to talk about the cost. Now, when you're going through, you should be using some sort of financial form, report of findings form that lists what therapies they're getting and then also the costs. And I think, so imagine if you had this sheet, and it's not filled out, obviously, but if you were just to put this in front of a patient's face, where does their eye immediately go?
Yes, I'm going to go down that bottom right-hand corner.
Yeah, like what is the total?
Yeah.
And so if you do that, if they see that, most patients, they kind of go deaf for a little bit. And so they're all of a sudden sort of kind of trying to work back. Well, why does it cost that much? And can I afford it? So all these questions start popping up in their brain. So what we do is when we're going through this, these recommendations, we actually put a sheet of paper over what we're not covering at that time. So for example, in this situation, we would put a piece of paper right below where it says knee visco supplementation. So Sam, remember how we talked about those hyaluronic acid injections? you're going to do a series of 5. So you have a $20 copay for that injection. We're going to do 5 visits. So on the right here, that's $100 total for that series of injections. The good news is that your insurance covers a majority of that series of injections. And then we move down to the next row. So the next row is durable medical equipment. This is the knee brace. So you have a $50 copay. It's 1 knee brace. That's $50 total. And again, your insurance covers most of that piece of equipment. So now we get into decompression. So we move one line lower, $50 a visit, 12 visits. Total is $600 on the right. And then we do regenerative medicine, the same thing. So at the bottom, you see just going through each therapy as you mentioned them earlier. And at the bottom, you have a total. So here's a total for your care. Now, so this way, they've heard all the information, they can process it. Here's the total. Now, the next question is, what would you like to do? And there's a few different ways to present this total on how they want to pay for it. There's a couple different strategies. One strategy is just very simple. It's, all right, Sam, your total is $4,000. How would you like to pay for that? We take cash, credit card, or check. And then silence. The other strategy is you can offer options. So Sam, the total is $4,000. We have 3 different options. The first option is you can just pay it in full. We take cash, credit card, check. The second option is we can do half down today, which would be $2,000 today, and the other half a month from now. So 30 days from now, we'll pay the last half of it. Or we can use, we have a patient financing company called Care Credit. Care Credit will allow you to finance the care over a period of up to 5 years. So it'd bring like a monthly payment down to roughly $100 or so for care. Which one of these makes the most sense for you?
Yeah, I love that. I want to go back if we could just real quick. Let me see if I can. So as you were saying this, I'm like, when you have the, I was getting kind of that sensation as you were, as I got the visual of you, like revealing one of these, of these rows at a time. I thought to myself, you know what? You need to pre-frame right before this again. Like you need to just say, hey, Andrew, I've got a list of the doctor's recommendations here. We're going to go through them one line at a time. That way I can explain to you how many you need and why. And then we'll get to how much, what the costs look like. Sound good? Right? Because then there is a level of anxiety of, again, anytime there's a level of anxiety in your mind, I think it's a litmus test of, oops, I forgot to pre-frame, and there's a level of anxiety of, even though they can't see that cell, they know it's down there, they know it's down there. But if you just say, hey, we're going to go through them one at a time. I want to explain to you how many you need, what's covered by your insurance and why. And then when we get to the bottom, we'll go over payment options. Sound good? Great. So anyway, I just thought how timely it is to,
That's so right. Yeah, that's so right. Yeah, that's a really good point. I think you definitely should do that, because you're right. You're creating some sort of like tension there. And if you don't break the tension with that little piece of paper, because they know what you're doing when you're doing that, but it should be explained. You're absolutely right.
I love it.
Yeah, perfect.
Cool.
Next slide. So the key here is that, like, when you're asking the options, just make sure, just like when you want them to identify that there's a problem, be comfortable sitting in silence.
Yeah.
So you've presented the total amount, you've offered the different ways that they can pay, and then ask them which one makes the most sense to you, and then just shut up. It might take 30 seconds, it might take a minute, it might take 2 minutes, it might take longer, but just be quiet. Let the patient work through the solution. If they can't figure out the solution, then you're going to hear it in terms of like a question or an objection.
Yeah.
And most questions, so here's where sometimes doctors kind of get offended, or they let ego get in the way, is that sometimes patients will ask questions, and oftentimes they're buying questions, but they just want they want an answer. Or maybe they say, I really don't know if I can afford this. I don't think I can afford it. Which is one way of saying, you know what, I really want care. I just realistically, I don't know how I'm going to do it. And so this is where you really need to be a good listener, and to understand that they're asking you for help on how they can figure out how to make it work. It's very rare when the patient goes, sometimes they overtly tell you, you know what, this sounds like you're selling me a bill of goods. I want out of here. And they just leave.
Yeah, if you go
Sometimes
through
that
the
happens, but it's
process.
pretty rare.
Yeah.
Yeah, it's pretty rare. Or
Yeah.
sometimes they're like, you know what, I need to go home and think about it, which is also a way of saying, you know, I'm really not interested, but I don't want to offend you. I just want to get out of here. But more times than not, they'll say, you know, I don't know if I can afford this. I think I need to think about it, which is where you want to step in and start helping them create solutions and ideas that maybe they haven't thought of.
Yeah.
You're going to say
I
something,
think,
Sam?
well, I was just going to say in that instance, it is important to, the primary objective is what's going to come from the silence. Okay. And I think what you want to do is isolate the objective. So if somebody says, you know, you said, I don't think I can afford this, right? I would say something to the effect of, first of all, I would repeat back to them what they said. So you're concerned about the costs. Is that right?
Yep.
And then, you know, I would get the response, is there anything else you're concerned about? No. Okay. So it's just the cost. And then as long as you isolate the objection, then it gives you permission to address it. If there's other things, you need to like knock them down one at a time. And the biggest one being the last one that you knock down. Right. So in this case, you know, again, pricing is usually the biggest objection that people have. I shared this earlier. It was something that I learned from Sunny. I really, really, really love it. If they say, you know, if they said, so you're concerned about cost, that's your biggest concern? Yes. Okay. Well, at our office, one thing that we want to make sure of is that cost never becomes an issue for somebody who wants to get help. Okay. So rest assured, we're going to do what we can to help you. And then you move down to the next, whatever it is. But even just saying that gives you permission. You address their concern and then you redirect it to, like you said, Andrew, solutions. What other solutions can you do? So we're on the solution page. What can we do?
Yeah. Yeah. So what I would not do is start lowering your price. That's a mistake. So I wouldn't say, all right, you know what? Yeah, that is expensive. And I could see how that could be difficult to afford. So let's just take 20% off. Would that work for you? And all of a sudden it cheapens what you're doing. And I like this example. I use this on the live training. I helped years ago. I helped my buddy who wanted to get married. I went with him to go find an engagement ring for his girlfriend, and he had exactly what he knew he would like, and he told the guy at the jewelry store, "Here's exactly what I'm looking for," and he pulled out this ring, and he goes, "Here is the ring that you described." And my buddy's like, "Oh yeah, that's exactly it. She would love that." And he said, I can't remember what the price was, but he said like, "This is $10,000." And he goes, "Oh man, it was really a lot more than I was hoping to spend." He's like, "Is there any wiggle room in the price?" And the guy's like, "Well, if you don't have a budget for it, I can always show you something different." And so he brings out a second ring, which was much smaller and not quite as fancy as the first one. and and he's like, "Well, based on your budget, I could offer you this ring." And then my buddy's like, he's like, "I don't know." And the guys are like, "Just keep in mind that you're going to present this to your girlfriend and ask her to marry you. You're going to spend the rest of your lives together, and she's going to have this ring on her finger and be looking at it every single day for the rest of her life. Do you think you could find a way to pay to afford this ring versus the smaller one? Is there a way that you can do that in your budget?" And my buddy, he's like, "Oh man, it's a good point. You're right. Yeah, I like this other one. I like this bigger one." And
Yeah.
so he ended up buying the bigger one, but the guy didn't have to come down on his price anymore. And he was smart to do that. But he also, if my buddy was like firm, he's like, if my buddy said, "No, my budget's $5,000, that's all I'm spending," the jeweler had a backup plan. He's like, "I can sell you this ring for
Yeah.
$5,000." So there was an option there. And so take this with Sam's knee problem, right? You know, the other thing you can do is you can say, "You know what? I'm sure we can help you. We can stick to what your insurance covers, which is hyaluronic acid and knee braces. And I'm sure you're going to get some relief with that. My concern for you is that, down the road, 5 years down the road, I just don't want you to be in the same position, having to look at potentially knee surgery or, letting this problem get worse, because you mentioned before, you understand that this is going to get worse, right? And so we want to do everything we can now to stop that from happening. So you definitely have options, but we want to make sure that we're providing and presenting the best options possible for you. So that being said, is there any way that you think you can, that you can afford this? What can we do to help you make that affordable?
I
And
love
then
it.
let them answer.
Yeah.
And so, you're showing them that you care. You're showing them that you're not just immediately dropping your pants on price and just giving it away for free. Spend some time in having sometimes those uncomfortable conversations, and you're helping move the patient along. So if all else fails, if they're like, hey, listen, I haven't worked because of COVID, and money is really tight. I'm really, I don't think I can afford it. So then you can start maybe taking some of the things away, like instead of the big ring, you give the small ring. So just maybe do the insurance-based therapies. And here's the deal, guys. If you, let's say I started Sam off in our office with just hyaluronic acid injections and just a knee brace, you have an opportunity with that patient to follow up with them later on down the road. So let's say Sam comes in and it's 6 months after his initial visit, he's done hyaluronic acid, he's done the knee brace, and he comes in for a re-exam and he's like, I think those hyaluronic acid injections, they helped. I'm like 70% better. Hey, that's awesome, Sam. Great job. We're happy for you. Let would you like to continue seeing results with your knee? If you remember 6 months ago, we talked about decompression and we talked about regenerative medicine. Um, is that, financially, is that something that you might want to revisit at this point? And he might be like, yeah, you know what? I got a job again and things are going great. And so
Yeah.
just because you didn't close the whole package, so to speak, on day one, doesn't mean that you can't do that 6 months down the road.
Yeah.
And
You got
I think some, yeah, some doctors just go for, they go for the grand slam. And if they don't get it, well, what about a home run, or what about a double or a triple? So start them on something. And some doctors are like, you know what, that's sacrificing the quality of the care that you're delivering. And in my opinion, it's not, right? If you can give them something, if you can give them some relief, even if it's not what you recommend, in an ideal world, sometimes you have to meet your patients where they are. And if you can give them some results and deliver for them in some meaningful way, then they're going to come back and they're going to trust you and they're going to feel like they haven't been manipulated. And
yeah.
sometimes it's just reality. You have to meet the patient where they are.
There's a lot of different people out there, and timing and circumstance have so much to do with those buying decisions too. And sometimes you date for a couple of weeks and get engaged, sometimes it takes a couple of years and you get engaged. The reality is yeah, I mean, if you don't hit a home run and you're unwilling to meet the patient where they're at, shame on you. I mean, you're missing out on tons of opportunity. And it's funny because so we're at the very end of the process, right? Like we're actually now not negotiating. We're adjusting and modifying the offer, which then modifies the cost. But I do find it interesting too that there's also doctors that will do this same thing. They will give up. Okay. Or basically they'll say, well, they didn't accept all my recommendations. So, or they have an objection. So, this is done. I can't tell you how many clinics that I have worked for in the past from a capacity of marketing. And then when I was consulting, and they just could not figure out that they were their own worst enemy. They weren't doing any pre-framing. They weren't listening and actually understanding people and their objections. They weren't, making any accommodations to help them. And like you said, have you ever heard of the puppy dog close?
It sounds familiar, but couldn't tell you what it was.
Yeah, so the puppy dog close is if you work at a pet shop. Oh, just take the puppy home for the weekend and bring it back on Monday. If you don't like the puppy, car salesmen used to do this. Basically just get them using it. Like give them a new reality, what it would be like to do the thing. And that same thing happens with care. Okay, if somebody's coming in for in this case we're talking about knee pain. If somebody's coming in for knee pain, and they're like, you know what, I don't know that I could afford a $4,000 or $5,000 thing. It's like, okay, listen, we don't let cost be a reason why somebody doesn't get the help they need when they're in pain like you are. And so you start modifying down. And one modification might be just, this is a random idea off the top of my head. Listen, Andrew, I know you're suffering from pain. I can see it in your x-rays. What if we did this? What if we got you under care for the next 2 weeks? So we're just going to give this thing a test drive. We're going to see how well you respond to this, this, and that. It'll cost this much. And then at the end of that, we can readdress this and see if this is something you want to move forward with. Again, sometimes you got to date. You got to go on a couple more dates before you can be engaged. But I just think that anybody, if you're getting to this point of a report of findings and somebody has basically verbalized that they have a problem, that they do want to make a pivot forward, a shift forward, by the time you get to this, it's in your hands. Whether or not that person enrolls into care, it's completely up to you. For the most part, I just think that most of the time people are just kind of closed off to the idea that they might adapt and, accommodate people.
Yeah. And also, if you're at this point, you should have at least should be about 10 minutes in to handling objections and financial questions before you ever hit this point. So if you're starting to either reduce your price or reduce your cost 2 minutes after you've just told them what it costs, you haven't done a good job at trying to help them figure out solutions.
Yeah. So what do you do if that's the case? If somebody starts asking about cost, I didn't mean to interrupt you. What do you do?
Yeah. So meaning like how they can afford it?
Well, you had said if you're talking about cost, like a couple minutes in, then you haven't.
Yeah. So, okay. So we would start with the most affordable is to do a pay in full option. And they're like, no, I really can't do the pay in full option. We would say like, well, you can use a credit card for that. So if you want to, you can, pay that through your credit card, but that's the most affordable way to do it. Like, no, there's no way I can do that. So the second option would be, okay, let's look at doing the half down, half later option. So the nice thing about this is it's, $2,000 today, and that gives you like another month to figure out your finances. And then the rest of it is just due, a month from now. And we'd even go, so if they're like, you know what, that would be a lot easier. And they're like, yeah, I think that's kind of the way I would want to go, but like, man, that's still going to be really tight. If that seems like it would be a good option, we'll even break it up into 3 payments. So we'll do thirds. And oftentimes, like if they're right on the fence, usually that's enough to sort of put them over. And if that's still not an option, they're like, wow, like $2,000 is a ton of money for me. There's no way I can do that. The third option would be patient financing. And so with patient financing, that drops their payment down to like a cell phone payment. It's like super, super affordable to do. They can pay it off over years versus months. And that usually is like the final option. And so if we're like, you know what, there's no way I'm going to get approved, my credit's awful, or maybe even do like a credit check on them to see if they apply for patient financing and their credit's awful, they get denied. Then we go into this final stage, which is either removing services or just getting really creative, like you mentioned, doing like a 2-week trial run. That's when we start to get out the really creative solutions. But you should spend at least like 10-15 minutes trying to figure out the conventional ways to pay first.
Okay, perfect.
And then the last concept we want to talk about is who should be doing the report of findings. And we had, as a doctor, I'd never liked doing report of findings. I always found them uncomfortable, but I was good at it. And we needed the money in our practice. So it was an important job. And I always felt like I was the one who had to do that. And I had to do it. It was on my shoulders. But once we started to develop a team, I realized, well, man, I could train somebody to do this. And I started developing and putting a lot of time and energy into training a case manager. So we had a gal named Tammy. Tammy had worked for us for a couple of years, and she had no real problems asking for money, and she really was into the care that we provided. She actually started off as a patient in our office and would refer tons of people. She was just a huge fan of what we did, and so she ended up working for us. And she was very passionate about helping people with unconventional or holistic therapies. And so she was the perfect person for that role. And so we trained her. So I had her shadow me for a couple months, and I spent a lot of time outside of normal office hours practicing scripting and role playing and objection handling until finally she got to a point where her closing rate was higher than my closing rate
Hmm.
consistently. And I'm like, man, and it was so nice. I remember a day that I was gone for a seminar. I was on a Friday, and I wasn't there in the practice all day. And I remember the first time we had closed like 2 or 3 patients on that Friday, and I wasn't even there. And I'm
Yeah.
like, man, that's so cool. It was so freeing. It was so liberating to know that that happened. And now so I'm saying that to say that you can absolutely train somebody to do that, but there's a progression that you need to go through to do that. So don't take this information and say, I've got the right person for it, and just throw them into that role. It takes some time to develop that into a person. But I will tell you this. The reason our case manager closed better than I did is because she had no emotional attachment to the final outcome. Because when I go into reported findings, I'm thinking as a business person, like, man, it would be great if this person came on board. This would really help us have a great month. Or, hey, this is a $4,000 kit. That's the stuff going through my head.
Yeah.
That sounds bad, but it's realistic. Yes, I
No,
want to help
that's
the
every
patient,
business
but
owner.
it's
Yeah.
real. It's
Yeah.
real. And if you're not thinking that way, then you should think that way, because you're running a business. So the nice thing but subconsciously that affects your dialogue, and there's a motivation attached to that. Our case manager Tammy had none of that pressure, none of those concerns, and she was able to just focus on the patient and how to help the patient figure out how to start care. And it got to a point where I didn't even have to. The patient didn't even see me on day 2. They would come in, go over results, make recommendations, start care, and then they were a patient, and I had no actual like touches with the patient on
Yeah.
day 2.
I'm going to go back to the pre-framing idea on this because early in the live training, we had gotten into a bit of dialogue on how to do this, and I think it merits sharing here in the replay that so Tammy, that was your case manager. Tammy, when I would imagine when she went into her report of findings, I would imagine she would have started by saying something to the effect of, hey, so-and-so, it's awesome to be here with you today. So I have Dr. Wells's recommendations here. He sat down last night, went over your images, went over everything he feels like is the best approach for you to not only get some relief, but also get a resolution. And I'm going to present his recommendations, right? So they pre-frame what's going to happen, that it came from the doctor. Okay, that's the first thing. That's one approach. And I'm guessing she did something like that. The second, did she do that?
Yeah, you know what? Yeah, you know what we did, and I totally forgot this. I was thinking about this after our live training. We would actually do that on day 1.
Oh,
So
really?
when we're closing day 1, I would say, I would take X-rays and I'd say, hey, Sam, we're gonna have you come back as soon as possible to review your findings. When you come back on day 2, we'll have you come back with your wife, and what we'll do is you'll meet with Tammy, our case manager, who by the way you just met with before for your consultation. Like, remember,
Yeah.
Tammy, she did your consultation. You're going to meet with her again tomorrow, and she's going to go over your exam findings, your X-rays with you, our recommendations. I'm going to meet with our providers tonight, and we're going to look at your X-rays and exam findings, and we'll come up with a solution for you. And Tammy's going to go over that with you tomorrow, with your wife. So that was that. We did the pre-frame on day 1.
Okay, that's so perfect. So perfect.
And then in the beginning, when Tammy was kind of new, and I think this is what you're leading into, when Tammy was new at it, I would just poke my head in on day 2 and say, hey, good to see you again, Sam. Oh, you must be Sam's wife. Nice to meet you. Great to have you guys back here today. I just want to let you know, Tammy's going to go over your X-rays today and your results. She knows what she's talking about. You're in really good hands. And yeah, if you guys have any questions or need me, just let me know.
Yeah, I love that.
And that's it.
That's perfect. I think anybody listening to this, if you're not doing there is, in my opinion, now sometimes you don't have a choice, and it's not like you're going to suffer, as a result. But in my opinion, always having somebody else deliver information on your behalf, so a case manager presenting a care plan over the doctor, is by far the preferable way, because doctors are supposed to be doctoring. They're supposed to be helping and providing the therapies and the advice. And so everybody kind of has their place, their role in the ecosystem. And if the doctor is over there like talking money and all that kind of stuff, while I think, again, if you're watching this, you're like, well, I don't have a Tammy. I get it. That there is a way for the doctor to present it, but in an ideal situation, it is as we described. The doctor is the person who is, meeting with the patient on a patient doctor basis, not a patient money basis. So I think that's really good. Well, I would say this has been absolutely phenomenal. In fact, it might have been, we did it in less time this time through, but the points we made were a lot like more concise. I thought it was absolutely phenomenal. And when you think in terms of what we covered last week in part 1 of day 2, and then the week before when we talked about day 1, specifically these 3 trainings, if you can't watch these trainings, take notes and get ideas and improve your process, you're not paying close enough attention, because there's some, I mean, the pre-framing, how to do that, the tactical approach to doing that over and over and over again, that one thing all by itself, that can change your practice. So I guess in terms of summary or anything maybe you're remembering from earlier this morning, anything else you want to share before we kind of conclude here, Dr. Wells?
Yeah, just to expand on your point, what took us from a 6-figure to a 7-figure office was training on the stuff we've been talking about over the last 4 weeks. It's day 1, day 2, day 1, day 2, day 1, day 2, over and over and over again. We got so good at day 1, day 2, and reported findings that it's just like, all right, then it's just a matter of, how many patients can you get in the doors and how many can you see from a volume standpoint. But marketing means nothing if you can't close patients on the back end of it. So if you can get these systems in place, and if you're working with Sam to bring leads into your practice, it becomes a win-win situation. But so that's what we're going to do. So next week, we're actually going to show you what a report of findings looks like in action. I'll be the Tammy, Sam will be the patient, and we'll show you live like what it looks like. And so we'll throw some objections in there, questions, and we'll make it as realistic as possible so you can see sort of live how the report of findings unfolds.
It's going to be a lot of fun. And what's been great about this too is even as we have gone through this, we talk about what people should learn, the subconscious stuff, the psychological principles, but we're also layering in tactics. The next one is going to be a complete, it's going to be a complete tactical implementation of what we've been talking about, which I think is really important. And if you're looking for magic in the role play, you're not going to find it. But what you will find is practice and redundancy. I was having a conversation with one of our users yesterday. We did a case study with her, Michelle Sims, and she was talking about how they train and how they're looking for small incremental changes, right? They'll take a Post-it and they'll put it on their computer and they'll say, make sure that when we're talking with prospective patients, we say, oh, Dr. Sims is an expert at dealing with neuropathy. You're in good hands. Like, they have these little phrases that they want to make sure they include in those phone calls, as well as things they don't want to include in these phone calls. And so next week is going to be cool. We'll be able to tactically approach a scenario, a report of findings, what that looks like. But hopefully these trainings are something that you will go back, watch again, take notes on, look at your process, say, we're not doing this thing. So we're going to start by doing this thing, right? And as you do that process, you'll create your own version of your day 1 and day 2 using, some tactics and guidelines that we've shared here today. But I got to tell you, this has been invaluable. Dr. Wells, thanks once again. And to anybody who saw this, thanks for checking us out. And I guess we'll see you on New Patient School Friday. See you guys.